Good morning, everyone. Welcome to IC365, Peripheral Ulcerative Keratitis, Evidence-Based Strategies for Diagnosis and Treatment. So I have with me very experienced co-instructors. I just request them all to join on the dais. We have Professor M. Vanathy, who's going to take you through a simplified algorithmic approach to clinical diagnosis and investigations. After that, we have Dr. Sarath, who is going to cover shifting the paradigm of medical management, new modalities and treatment strategies. Then Dr. Niviti Lomi will cover a customized surgical treatment approach, patches and matches. And finally, myself, Dr. Radhika Tandon, will take you through some interesting cases which will illustrate all the principles that you would have learned before. So with that, I welcome you all, and I hand over to Professor Vanathy to start.
Thank you, ma'am. So I think in the next 10 minutes or so, I'll just simplify the practical approach to management, or a practical approach to, I think management will be covered by the speakers coming on after me, to a clinical diagnosis and investigation. So it's more of a clinical-oriented talk rather than in the theory of the subject here. Have no financial interest in the mention of anything during the course of my talk here. So when you look at peripheral ulcerative keratitis, so which means the ulcer is situated in the periphery of the cornea. So you have a 360 degrees limbus. So it's there anywhere around the periphery of the cornea, and the word ulcerative means that the epithelium has broken down, and so there is an ulcer which is present, and it can be of any configuration here. Normally when people refer to PUK, the first picture which comes to their mind is it looks like it's a Moran's ulcer. So everything tends to look at or be treated like a Moran's ulcer. So that's a concept which needs to change, and you have to understand that a peripheral ulcer can occur because of several reasons here. So I've just placed the top reasons here. This is not an exhaustive list, but this is the most common things which one might see in anterior segment practice here. So the first will be a marginal keratitis here. So when you do look at these patients in very early stages, the marginal keratitis commonly occurs secondary to or along with a lid pathology, a blepharokeratoconjunctivitis here. And it starts as an immune pathology because of the immune toxins of the staphylococcal species which are colonizing or along the lid margins here. So these tends to be a local immune abscess here. And if this is not treated correctly or recognized correctly, the abscess tends to give way because they are just necrotic tissue, and then forms an ulcerative lesion which can be mistaken for an infectious keratitis or for a Moran's ulcer type of a keratitis. And this commonly would occur on the upper limbus, but it's not an exception. It can occur in any part, commonly the upper or the lower limbus. So that's another common clinical condition when you see an untreated blepharokeratoconjunctivitis with you. Again, you can have simple infectious lesions caused by gram-active, gram-negative, which can occur in the periphery of the cornea. And the periphery, if you have a viral lesion which is presenting like similar to a PUK, then you would probably go back and look at if this is an immune-compromised patient here. So these are the patients who tend to have peripheral lesions earlier here. So those are infectious and the herpetic presentations. Flectanulokeratitis or flectanules secondary to severe allergic disease, you usually will have telltale signs in the other parts of the eye, which says that this is an eye which has been predisposed to recurrent or chronic ocular allergy. And when flectanules which are occurring in the periphery break down, they can cause an ulcerative lesion, but this is usually a lesser thing which you would see, and you would find features of frank limbitis and infection which probably leads to the ulceration in such cases. Another common scenario would be in elderly, where you can have peripheral furrow degeneration, senile furrow degenerations, which can mimic peripheral ulcerative keratitis, and Tyrion's marginal degeneration. This is a non-inflammatory lesion and will not have infiltrates and will have associated corneal thinning here. So the first and foremost, when you're looking at a PUK vis-a-vis Moran's ulcer, you would look at the scleral involvement. So whenever you are having a scleral involvement, I always you should be alerted that this has an etiology, and probably you're not looking at just a Morans. And again, the other signs of presence and absence of infiltrates, the lesion being more virulent or less virulent depending upon the morbidity of the lesion. So I'm just going to run you through the important differentiating features in systemic examinations which can point you towards a PUK which is occurring secondary to a systemic, like a saddle nose deformity, an auricle penne. You can have oral ulcers, mucosal ulcers, butterfly rash of the face. These are all telltale signs that the patient is having an SLE or a relapsing polychondritis. Systemic sclerosis features like telangiectasia of the vessels and facial vessels, rhinophyma. Vasculitis will have other systemic features usually associated, and the pertinent features for giant cell arteritis is temporal artery tenderness, Raynaud's phenomenon in systemic sclerosis, SLE, Sjogren's here, subcutaneous nodules if you look at rheumatoid arthritis. So most commonly you will find PUKs in rheumatoid arthritis patients secondary to the dry eye disease and the immune pathology and the disease of the ulcer here. Similarly for GPAs and for polyarthritis nodosa, relapsing chondritis, I think I would refer you to go back and look at the systemic features which could be present in these patients. A quick run through of what you need to do when you're looking at a PUK which is associated with a systemic disease here. The first and foremost is simple blood investigations for the patient. You would look at C-reactive proteins, the nephrology investigations, immunological investigations will include C-ANCA, P-ANCA here, anti-nuclear antibody titers, rheumatoid factor if you're looking at a rheumatoid-induced pathology, anti-complement factors here, ACE, and specific tests for any suspected infections like syphilis, tuberculosis, sarcoidosis, and imaging pertaining to this suspected infection needs to be done. This is in a nutshell the important ones which you would probably place to, and if you pinpoint something which is there, then you would probably coordinate with your treating physician here to look at more immunologic investigations for these patients. Morans is a diagnosis of exclusion, and when you do not have any point and you are having an ulcer, and usually Morans presentation is very characteristic, we have overhanging edge, and it could have a progression both circumferentially and laterally here, and can involve, when untreated, the entire, and even with treatment, can involve the entire circumference and might necessitate interventions in these cases. You do have a classification of a type 1, type 2, and type 3, depending upon whether they are unilateral, they are bilateral, and whether they are virulent or they're not so virulently progressive, and about the age group and racial differences here. So I think sometimes this does not conform to the pattern, and you would find something which is supposed to be benign being more malignant, and vice versa itself. But usually the clinical feature is quite confounding for these patients here. Just run you through quick examples before I stop here. Here, this is how you're finding a large peripheral gutter which is also extending for quite a significant region in this region, and what you need to watch is the thinning, because this might perforate in cases of Morans here, and that would warrant an intervention. This is a case of blepharokeratoconjunctivitis where you could see the lid is obviously infected with severe morbidity here, and you have lesions which have started developing here. So this you would probably need to treat with steroids rather than bombarding them with fortified antibiotics, because that will only lead to the increase in the immune abscess. A patient with syphilitic peripheral ulcerative keratitis, you see the rest of the cornea again has got involved, and you have intense anterior chamber inflammation as well in these cases here. Again, if the peripheral ulcerative keratitis has been left untreated for long, it cannot withstand, the thinning cannot withstand the raised intraocular pressure, or progressive necrosis by secondary infection can lead to perforation such as this, and you will have to intervene for management in these patients here. Small peripheral lesions can heal well, and remember, whenever there's an associated scleral thinning, there is a pseudopterygium formation because the limbal stem cells have also been affected here, and the neighboring conjunctiva tends to grow over and cause the healing and also compensate for the corneal thinning here. This is a picture of the Tyrion's marginal degeneration here. And again, you look, it mimics an ulcerative lesion, but you would have epithelium over this here. It's usually a quiet eye here, associated thinning, and you would have this lucid interval, and you also have the lipid pigmentation, which are all characteristic features. So a quick run through on an algorithmic approach. History and clinical examination will remain the key to decide what are the causative reasons for the what are the reasons why this particular PUK is occurring here. Apart, once you've examined and you've come to a reasonable conclusion, your investigative modalities will depend upon what is your conclusion or what is the empirical diagnosis. Is it infectious? Is it immune? Is it allergic? Is it a peripheral degeneration? Or is it associated with systemic causes? So you'll have to learn to divide whether it's an ocular or a systemic disease-related presentation in the eye here. And you'll have to differentiate important and immune is blepharokeratoconjunctivitis and Murans. Your basic workup, again, remember, corneal scraping, if you find an infected component, is always mandatory because you need to rule out infection before you take on. Basic workup of hematology and the related investigations here. Immunological workup for these patients, test specific for the particular infection which you are suspecting here, and imaging modalities pertaining to that incision. So you don't need to run a battery of tests, but run what is pertinent for your particular empirical diagnosis for the patient here. I think I'll stop here, and thank you for your patient listening, and thank you, ma'am, for the opportunity to be part of this.
Thank you so much, Dr. Vanity. So Dr. Vanity very nicely covered the beginning of the journey of looking after a patient who presents with peripheral ulcerative keratitis. So in your mind, you make up, you have a kind of a protocol, clinically you assess the patient, try to make a diagnosis on day one, and then you tailor your investigations and subsequent planning of treatment according to the response and what results you get. So that is the first step. And as she nicely indicated that there is a journey you go then, which path you take, what treatment you do, and it is usually always everybody's interest that the patient be medically managed, and this is one disease where appropriate medical treatment at the right stage can completely reverse the pathology or at least contain it. So with that, I'd like to introduce to Dr. Sarath. He is going to cover our next approach that you've started the treatment and what will be the paradigm or the changing paradigm in the medical management, giving you a sort of an evidence-based guideline. So over to Dr. Sarath. And I'll request anybody in the audience who has any question, if it's a very major question related to a particular talk, we can take right after the talk. Otherwise, we will take the questions at the end.
Thank you, ma'am, for the kind introduction. I'll be dealing with the shifting paradigms of medical treatment in PUK. I have no financial interest, and I thank Dr. Yogita Gupta for providing me with some of the slides. So the overview of this presentation would be medical management of PUK, which can be a local therapy as well as a systemic management. And management includes mainly steroids as well as immunosuppressants, newer modalities like biological therapy and other newer treatments. So before going into the newer modalities and the paradigm shifts, I'd like to talk upon the classical treatment, medical therapy, which is being, just a second. Okay, thank you. So classical therapy and the goals of treatment. The main goals of treatment would be to promote the epithelial healing and halt further progression of the stromal lysis, which is being caused by the inflammation, as well as prevent secondary infections. And prompt treatment reduces mortality as well as the ocular morbidity associated with PUKs. So clinical situations can be either an infectious pathology or a non-infectious pathology, and differentiating these with the investigation as well as clinical examination is very pertinent. So first would be a non-infectious cause, which can be associated with systemic immunological diseases and collagen vascular diseases, or if you can't find any cause for this, you will label it as Moran's ulcer. On the other hand, you can have an infective pathology or with a secondary infectious upon an inflammatory pathology. So medical management should be cause specific, and having a tie-up with a rheumatologist is very important, because often you have to shift some of the biological therapy, or you have to titrate the dose of the medicines, or due to side effects you will have to stop the medications. So having a rheumatological referral is very important, and local therapy still holds a mainstay of treatment along with systemic treatments. And first, when you exclude the infective pathology or inflammatory pathology, you will have to add antimicrobial coverage to prevent secondary infections. So medical therapy of PUK in case of systemic autoimmune or collagen vascular disorders can be local therapy or systemic therapy. So copious lubricants for epithelial healing is very important. You can halt the collagen lysis with collagen inhibitors either topically or systemically, and low dose antibiotics for preventing infection or treat infection. Topical steroids are the mainstay of treatment. You can add on adjuvant therapies like cyclosporin. Systemic therapy includes corticosteroids, prevents stromal lysis with oral tetracycline, or disease-specific immunomodulators, vitamin C for healing, as well as systemic infection should be treated. So this is the overview of treatment in cases of PUK. And aggressive immunosuppression is very important in cases of aggressive cases or recurrent cases. And as I said, rheumatological consultation is very important. In cases of infection, if you suspect an infectious cause of PUK, corneal scraping should be taken, and empirical antibiotic, either fortified antibiotics or on monotherapy can be started. And depending upon the size of the ulcer, you titrate the dose. Culture positive, as in case of any corneal ulcer, which is an infective pathology, you treat according to the culture positivity or negativity. So I'll not be dealing much into this. Next is Moran ulcer. It needs a step ladder treatment protocol, where initially you start with topical steroids, then a surgical treatment of conjunctival recession, and then systemic immunosuppression or additional surgery and rehabilitation. So mainstay of treatment is topical steroids. It is required in cases of all immune inflammatory PUKs, and administer as per the severity of symptoms. If you feel that it is severe, then you give the steroids in a frequent dose. Initially, you can start with low potency steroids like a fluoromethalone or loteprednol if you think that the pathology is not severe or the symptoms and signs are not severe. In cases of rapid progression or severe cases, you can go for a higher potent steroids like a prednisolone phosphate or betamethasone. So usually it can be started QID, or it can be started too early depending upon the severity of symptoms. Caution should be taken when you think of an infective pathology. You treat the infection first and then you start the steroids. Adverse effects can be corneal perforation, steroid-induced glaucoma, cataract, and susceptibility for secondary infections. Next, adjuvant therapy would be lubricants. As I said, copious lubricants should be given, which is preservative-free. And next would be a topical collagen inhibitors like acetylcysteine, 10 to 20% QID dose can be given to inhibit the collagen lysis and prevent further inflammation. And anti-glaucoma medications to control, often these has inflammation and causes the IOP rise. So it should be treated with anti-glaucoma medications to prevent perforation. And cycloplegics for symptomatic relief, and autologous serum drops can be used in case of severe epithelial defect. It enhances the healing of epithelium. So other systemic medications, topical medications like oral NSAIDs, systemic medications like oral NSAIDs, vitamin C, doxycycline can be used. And as I said, aggressive systemic immunosuppression and corticosteroids can reduce the morbidity. Systemic steroids can be useful in PUK with progressive thinning. usually it is started at a dose of 1 to 1.5 milligram per kilogram at a maximum dose of 60 milligram per day per person. And intravenous methylprednisolone may be considered in cases of severe PUK with systemic causes, and monitoring of adverse effects should be done. So, choice of therapy should be tailored depending upon the symptoms. And first choice would be oral prednisolone in the initial phases, and then you shift to a second line therapy like a immunotherapy, methotrexate, azathioprine, cyclosporin, mycophenolate, or you go in for a higher-ended, newer biological agents in cases of severe or recurrent cases, or in case you want to keep it in a remission phase. So, which is the right immunological agent, how to follow up, what to choose, when to initiate immunological agents, all depends upon the patient's severity of symptoms, recurrence, or associated systemic diseases. So, this has to be a custom-made treatment depending upon the patient's presentation. In cases of underlying systemic autoimmune diseases, you can start with immunological agents along with steroids. Once the steroids sets in action, the immunological agents will take a few weeks to start the action. So, steroid should be the initial mode of treatment in all cases. And which immunological agent to choose depends on the underlying, as I said, underlying diseases, disease severity, as well as the side effect profile. What are the immunological agents which you can use? Either you can use a topical immunomodulator or a systemic one. Topical ones are the topical cyclosporins like calcineurin inhibitors, or topical tacrolimus 0.03%. Systemic immunosuppressive agents may be methotrexate, cyclophosphamide, mycophenolate, mofetil, azathioprine, or cyclosporin A. So these has to be chosen depending upon the cause of cause of PUK. Is it vaginous granulomatosis, is it rheumatoid arthritis, or depending upon the tolerance of the patient, side effect profile of the patient. Methotrexate, a little bit on the different types of immunomodulatory agents. Methotrexate is an apoptosis inhibitor of T cells, and it can be given in a dosage of once in a dose, 5 to 25 milligram per week, and tapered over a duration of 12 weeks. All these agents can be tapered over a period of 12 weeks depending upon the response. And side effects includes hepatotoxicity, leukopenia, ulcerative stomatitis, nausea, fatigue, renal failure. Next is mycophenolate, which is lesser of side effects. It is an inhibitor of T as well as B cells. It is started at a dose of 1 to 3 gram per day, and tapered, as I said, over a 12 weeks period. The major side effects are elevated LFT, GI upset, as well as bone marrow suppression. Next is cyclosporin. It inhibits the T cell activity, which is a calcineurin inhibitor. 2 to 3 divided doses can be given at 2.5 to 5 milligram per day per kilogram, and tapered as required. Most common side effects are gum hyperplasia, hirsutism, and hyperkalemia. Next is azathioprine, which is a DNA synthesis inhibitor, and it is given at a dose of 1 to 2.5 milligram OD/BD doses. Side effects include skin rashes, predisposition to neoplasias. Cyclophosphamide, it is also an inhibitor of T cells, which is an alkylating agent, and single dose of 2 milligram per kilogram per day can be given. Side effects are bone marrow suppression, as well as other common side effects like nausea, vomiting, diarrhea. So this is a whole list of immunomodulatory agents which you can use with the dosage as well as the specific side effects. So how do you follow up these patients? These can be followed up depending upon the severity of symptoms. If you think that the patient has a severe symptom, you call the patient very frequently and assess the response weekly or after 3 days if the patient has an impending perforation. And on follow-up, you have to investigate and look for the systemic side effects with complete blood examination, LFT, RFT, as well as ESR and CRP, and chest X-ray to rule out infections. ESR and CRP will guide us to titrate the dosage of the drugs, whether the inflammatory pathology is being under control or not. The other blood counts, LFT, and kidney function tests are just to look at the side effects which is being imparted from the immunological agents. And so, as I said, this is the newer modality of treatment where biological therapy is being used. Anti-TNF alpha inhibitors like rituximab, infliximab, anti-IL agents, B-cell inhibitors, antibodies with specific targets, as well as immunoglobulins intravenously can be given. Infliximab is given in a dose of 3 milligram per kilogram. So side effects are infections, drug-induced lupus erythematosus. Next is etanercept, rituximab, adalimumab. Etanercept is a TNF alpha inhibitor. Rituximab is an anti-CD20 inhibitor antibody, and adalimumab is a TNF inhibitor, monoclonal antibody. So all these can cause serious infections and activate hepatitis B, dormant, tuberculosis, all these things. So you have to rule out infections prior to starting the treatment as well as during the treatment course. Or interferon alpha 2B can be given in cases of Moran ulcer with hepatitis C infection. So these are some more newer biological agents: obinutuzumab, golimumab, tocilizumab, belimumab, abaccept, and JAK inhibitors like tofasitinib can be used. So all these agents can be chosen in coordination with a rheumatologist. So they will be able to titrate the doses, monitor along with the clinical follow-up which is being done by ophthalmologist. So which therapy should be chosen, biological therapy or immunosuppressants? In the remission phase, it is recommended to start with an immunosuppressive agents like the steroids and other agents like methotrexate, cyclophosphamide and all. In the maintenance phase, you have to shift to a biological agents because it is a longer or a chronic phase where the side effect profile should be reduced. So newer biological agents will have a lesser of side effects which can be used for a longer duration and control the cause of POK or the inflammatory pathology without much side effects. So that finishes my talk. Thank you, everyone.
Thank you so much, Dr. Sarath. So Dr. Sarath nicely covered the whole spectrum of treatment, medical treatment options, and gave some idea about the algorithmic approach or the kind of step-ladder treatment that one would follow. Just a few points I'd like to make right here before we go ahead for the surgical handling. Firstly, not everybody would be getting the cases not everybody would be an expert in managing these cases, but every ophthalmologist who encounters a patient, if they have some idea about how to start, it can make a lot of difference. So here I want to stress about the use of topical steroids. When you are going to use topical steroids, we have to consider which steroid to use and what frequency. And the other thing is, as was mentioned by both Vanati and Sarath, that you have in the back of your mind that there is a possibility of an associated infection. Whether the infection is the first cause of the PUK or because of the ulcerative process and the epithelial defect, there's a secondary infection, you can never be sure. So largely, unless it's looking very, very clean, the first 24 to 48 hours, you should give a cover of topical antibiotics to make sure that you don't have an infection which is suddenly going to become extremely uncontrolled if you give very heavy steroids. And if you do feel that you want to give steroids on day one, then don't give very strong steroids like dexamethasone. You can start with prednisolone drops. And don't give like 1 hourly, 2 hourly, 3 to 4 times a day to begin with, because you just want to control the inflammation and take time to find out what is actually going on. And if it's very, very mild, you can even give fluoromethalone because you're not sure. You just want to control the inflammation, but you don't want any infection to sort of suddenly, burst out. That's one. And then don't hesitate of not giving the steroids at all. The first 48 hours, you can treat with antibiotics, check after that, and then you can give the steroids, because it's very, unless it's an extreme situation where you have to give very heavy steroids at the beginning, and then you can give systemic steroids, because the systemic steroids will not lead to the overgrowth of the local bacteria. And as you know, it's a systemic disease and has to be controlled systemically. The other thing is talking about the immunological agents. There is such a plethora of drugs available. It's very difficult for us as ophthalmologists to be up to the mark in knowing what works in which case. So largely, I feel uncomfortable starting the treatment myself, and I usually consult the rheumatologist, but not everybody may have access. So therefore, if you have a situation where you have to take a decision, just again consult one of these tables and then, look at all the columns and rows and select a good agent to start with. And rarely it happens that the rheumatologist says, no, no, from our side it's not required and you go ahead. And that happened to me with one case. And believe me, it was really difficult, and I'll show you later that ultimately the rheumatologist did have to step in because there's so many new drugs available, and you do have to have that expertise in knowing this is the drug and this is how it's going to work. But I would say that in such a situation, initiating the oral prednisolone makes a huge difference, and IVMP may be required in some cases. Not to forget that these drugs are expensive. So talking about the biological, we're looking forward to more Indian companies coming up with the made in India options, but they are expensive. And once again, one would see these cases intermittently and occasionally. So don't depend on memory. Again, look at the chart and look at the possible options and decide. And don't hesitate to consult. You can even consult a colleague by phone, send the pictures by phone, and just talk it over with somebody. And ultimately, the idea is to control, stabilize, and monitor. So with that, we come to then the next step of the journey, that despite all your efforts, or sometimes a patient comes at a very late stage, or the disease is such that irrespective of what you do, it progresses and it now requires a surgical intervention. So Dr. Lomi is going to take you through the choices and options and how to go about it.
Thank you, ma'am. Very good morning to you all. So, in this presentation, I'll go through the customized surgical treatment in this peripheral ulcerative keratitis where the perforation occurs. So, I'll go through the matches and the patches, the techniques used in this treatment of these perforations. So, I have no financial or any conflict of interest to disclose in this presentation. So, corneal perforation is an acute complications of PUK, commonly seen in cases with multiple recurrences, and if you are using inadequate immunosuppression or there is poor compliance to the treatments. So the indication of surgeries in PUK may be tectonic when there is increasing depth of melt leading to desmatocele formation, or in the impending perforation, or there's advancing extension of melt circumferentially or centrally, or sometimes in optical region also, after the active process has healed for the visual rehabilitations of ectasia, and also induce astigmatism, and also to maintain the maintain stability of the residual thinning. So the customized surgical procedure, there are various options that has been described that depends upon the size, the shape, the location, and extent of the tissue defects. So tissue adhesive with bandage contact lens can be used for perforation if it is less than 3 millimeter. Tuck-in tendon page graft is another important technique which has been described for perforation of 3 to 5 millimeter size. Tuck-in lamellar keratoplasty for 360-degree tectonic supports. And also we have got the tectonic penetrating keratoplasty if it is large perforations. And lamellar graft, that has a less chance of graft rejection, so that also is important to know. And also the various sutureless lamellar keratoplasty from the smile-generated lenticles. So there are various shapes which can be used for managing this corneal perforation. So the donor tissue is carefully sized to match the recipient bed, and the patches the peripheral defect accordingly. So there are various shapes. You can have the round shape, the crescentic graft, the biconvex shape, the banana graft, the stencil-based prick and print, and the C-shaped lamellar keratoplasty for the ectasia part of the corneal degeneration or corneal ulcers. So coming to the case scenario, here is a case with bilateral PUK, a known case of rheumatic arthritis, which has been treated outside with a glue BCL for the perforations. So patient has come to us with the perforations Recurrence is there with iris prolapse, and the glue has been dislodged on left eye. So we consider for this crescentic patch graft in these patients. So here, the bed of the tissue defect, the diseased cornea is dried and measured. So along with the thinning area, the excessive area is marked. So after measuring with the largest diameter, there's 9 mm here in this case, the donor graft has been refined. This is followed by preparation of the recipient bed. So with the marking of this, the recipient tissue, so you dissect along with this marking line. This followed by the placement of this donor cornea, and 3 anchor suture has been placed with interrupted 10-0 monofilament nylon suture. Then the residual other remnant bed, that diseased part is trimmed off. Now the donor cornea is matched with the underlying marking, and further the suturing has been completed. So this is the post-op day 1, and this is post-op day 5, which shows a good corneal, SC formation, and the cornea is relatively clear now. The donor cornea is relatively clear now, and the treatment which were given were the immunosuppression along with the prednisolone tablet has been given these patients, and the further rheumatologist consultation has been done in these patients. So next, even circular patch graft can be used for that perforation of 3 to 4 millimeter or till 5 millimeter perforations, where you can do a circular or round patch graft can be done. Next is a stencil-based prick and print technique. This has been published and described by Dr. Gautam et al. So in this procedure, they have marked the deceased host cornea, which is followed by making of stencil by pricking along the mark outline by a hypodermic needle of 26 gauge, and followed by cutting the prick outline. The transparent paper or plastic is used here, and this is printing is placed over the donor cornea, and the excision of the shape of donor cornea is done, and which is made and sutured over the recipient bed. So in this, they have found that there is 80% success rate, which is a technique which is simple and easy to learn. The advantage is that we can make any shape or pattern of donor corneal graft without involving the optical centers. Next case scenario is case of neurotrophic corneal ulcer perforation. So here we have considered for Tandon patch graft also in this video. First of all, the recipient bed is cleaned, and you need to harvest the tendons. The tendons is dissected and excised, a larger size than the perforations, and then this is followed by paracentesis, and then creating a corneal stromal pocket there. And the iris has been repositioned back to the anterior chamber, and you can place the tendons over the perforated area and try to tucking into the in the stromal bed. And then here I used a 10-0 monofilament nylon suture. You can use around 4 or 8 according to the size of the perforations. And some people use the glue, fibrin glue along with it, or you can use the cyanoacrylate glue. Or some has been described about the overlay with the amniotic membrane graft also. Here I have used this fibrin glue. All the viscoelasticity and then all the pigment that has been released has been washed off. Here another suture you can place, that there is restraining suture or the overlay suture. X suture can be placed over here to minimize or limit the extrusion of this the tenon page. So it has to maintain that the cross center should be over the perforation side. You can use 2x or the single 1x this suture also, followed by the placement of BCL. So you see in the post-op that the AC is well from now, but we have to be careful with the post-op management and then continuous follow-up of these patients. Another this tucking page graph it has been described by Dr. Namrata and Dr. Vajpayee et al. So in this they have shown that perforation of 3 to 5 millimeter size is where which tucking tenon page graft can be used, and the mean duration of epithelial healing is around around 4 weeks. The tucking page graft with glue it's an inexpensive and simple and safe procedure. Another advantage is that it is the tissue can be grafted, harvested. It's autologous and repeatability of the case can be done. And in case of acute perforation where we don't have the corneal tissues with you, then in this procedure you can consider for using tenon page graft. A case scenario another with PUK in a bed shades, where you see a necrotic scleral necrosis and with perforation there, and 360-degree peripheral acetylation with surrounding avascular zone. Here, a corneoscleral page graft was done in this case. Surgeon is Professor Radhika Tandon here. So the donor tissue is matched with the perforation, the defect size with a free hand cut, and that tissue has been placed over over the recipient bed, and it has been made a mark so that we can trim with a free hand according to the size of the defect. And it has been sutured back to this to suture in the recipient bed. So this is the patient has shown a very considerably gain good vision and follow-up also that maintain the integrity of the eyeball is there. Another smile-derived lenticle graft can be used in a small perforation or in a case of desmatocele or impending perforation, where a lenticles you can use a double or triple lenticles layers, and you can use a glue over it, or you can use a sutured of this donor graft into the recipient bed also. So it shows a reasonably clearer cornea graft, even post-op months also. A preliminary data from our institute, which shows a comparison of tenon page graft and smile-derived lenticles in the management of corneal defect and perforation, where on smile-derived lenticles have shown considerably clearer cornea with less of neovascularization and less of astigmatism. And lastly, the compression C-shaped lamellar keratoplasty, where at 9 mm of inner circumference and 14 mm of outer circumference has been marked over the donor tissue, and on the edge, you can use a dermatological refine of 2 or 3 millimeter size to make a C curve, and deliberately a smaller wide size of 0.25 or 0.5 mm can be cut for having a compressive effects, and also to overcorrect the astigmatism over there by 50%, so that you can reduce the severe corneal astigmatism in peripheral corneal ectasia. So in this series, they have shown that a good stable astigmatism in a range of 0 to minus 2.75 diopters cylinder within 6 months' times. So in conclusion, early surgical intervention along with optimal cytotoxic immunosuppression therapy will help in successful achieving the restoration of tectonic integrity of the globe and visual acuity, improvement and stabilization in the perforated PUK. Management by a team of internists or rheumatologists and ophthalmologists is paramount, and the judicious use of immunosuppressive agents may yield a relatively favorable results while managing the adverse effects. So the match and patch of the corneal graph, which is an easy steps under direct visualizations, is simple to perform accurate mapping, freehand or refined marking. But having said that, merely the surgeries won't help, so you should have an evidence-based approach is to have a minimal or optimal outcomes of these such patients. Thank you.
Thank you very much, Dr. Lomi. So, Dr. Lomi very nicely went over the entire range of procedures that can be done and how you may have to customize a particular surgical plan according to the patient's need. I will just add 1 or 2 points here. One is that depending upon the situation, sometimes the patients are very sick, and though you would like to do the surgery under GA, rarely it happens that it is not possible. So rather than say, no, it cannot be done, then you have to find a way out. Sometimes you may just have to give a facial block and just lid akinesia and then topical medication or subtenons anesthesia. Because if the patient is very sick and is in a very dire state, you do have to do the surgery somehow or the other. But otherwise, topical or under block also cases can be done depending upon the situation. The other thing is that sometimes it looks very daunting in the beginning, that how are we going to go about it? And the donor cornea, you may be using a non-optical grade tissue, so it's usually already a bit swollen. So after you make your matching shape, the posterior edge of the donor tissue, you can bevel it a little, so it's easier to tuck in. So that's one thing, because often the area of defect is there, and the tissue next to that, or even the sclera next to that, is melting. It's not so healthy, and you have sutures cutting through. So how far to go? So in such situations, you can just bevel it, and you can do a combined glue as well as sutures, because the benefit of the glue is it will give you a diffuse stabilization, and then the sutures can help. Sometimes that approach can also be taken. So with that, I'll go to the case examples.
Yeah. I think as ma'am is setting up, I'll just sort of rewind and go back to what we have been discussing so far, and I'll have a question for Sarath. Yes, Sarath, I think when the common difficulties which we face is when we are monitoring peripheral ulcerative keratitis requiring systemic therapy, how do you decide when you will use immunosuppressants and when you will need to use biological agents? Sarath.
Can you repeat?
When would you like to use biological agents or immunosuppressive agents?
In cases, immunosuppressive agents are generally in the acute phase where you want to start the steroids initially and then use the immunosuppressive agents along with that. In patients who don't tolerate immunosuppressive agents, or if you want to keep for a longer duration, I would like to go for a biological agents, the side effect profile is very less, but the problem with the biological agents they are expensive and might not be available for everyone.
Okay, can I have my slides, please? Yes. So one thing, if you find interesting, whenever you go to these talks of PUK or corneal melts, everybody ends up showing similar pictures. So there's something to do with the pathology. So everybody would see that often either there'll be a little round knuckle or there will be the crescentic. So there's something which just intrigues me as to something with either the disease process or the corneal anatomy and physiology, that this is how the shape looks. And as we know, what are the indications where you would have to go for your surgical technique? And I'm just going over this because these various decision-making process has gone through the cases that I will illustrate. Dr. Sharath, I think, mentioned the doxycycline. So the corneal melting, it is good to also support with adjunctive therapy such as vitamin C and doxycycline. Doxycycline is a matrix metalloproteinase inhibitor, and it reduces the melting process. So you can use BD, 200 milligram BD for 2 weeks and then OD for 2 weeks. So as I said, clinical evaluation, investigation, planning, systemic disease, comorbidities. Often the patients have diabetes. But if you talk to the endocrinologist, they say, you do what you have to do and we'll control the diabetes. So you have to work close together. If you have to give the steroids, you just have to give it because it's a sight-threatening disease. And in judicious use, of course, not everybody will give very high dose. But when required, then the endocrinologist will then put the patient on insulin and closely monitor, etc. So medical therapy, surgical procedures, and then don't forget rehabilitation. So after one has gone through all this, then long-term monitoring and follow-up to see what happens afterwards. And when we talked about the various topical therapies, so cycloplegics and additional anticoagulanolytic agents, and then systemic diseases as well. Sometimes they are really lethal systemic vasculitis syndromes, and usually it is the ones associated with a neck scleritis. So it is POK along with scleritis, and technically all of them will have a certain element. So scleritis is at a risk, so if you have a patient of scleritis, they will have a risk of getting POK, and correspondingly with POK, there's a strong likelihood that they'll have underlying scleritis, so watch very carefully. And so here are the case studies and the evidence-based, okay? So as I said, that you have this kind of a picture which could be a complication because often patients will have gone through different stages, come from different areas, and a lot of delay may have been there in initiating the treatment. So therefore, they may have an associated infection as well. Now let's take this case. This was a 55-year-old unmarried gentleman. Normally we don't take a history of high-risk behavior, alcoholism, etc. But the way the history, the disease progressed, in retrospect we'd ask. So this is again a lesson to us that when taking a history in these cases, don't forget to ask details about other diseases. So this is what the patient had. He had a vision of 5/60 in the right eye and have hand movements close to face in the left eye. And there were iris nodules, there was a pupillary membrane, there was aphakia in the right eye. In the left eye also he was aphakic with no past history of any surgery, and there was a pupillary membrane, and then there was this PUK with necrotizing scleritis. And the right eye also showed some scleral nodules suggestive of nodular scleritis. So ocular features, it was a bilateral disease, there was element of scleritis, there was anterior uveitis, and there was aphakia. And then on systemic investigation, he also had a genital ulcer. It was a single oval-shaped ulcer. This was done by the dermatology and BD clinic, and it was painless and indurated. So with all this, we had the background that, and of course, the pupils were not dilating. One couldn't visualize the posterior segment easily, but there were posterior dislocated crystalline lenses. Specimens were sent for microbiology and autoimmune screening. He was treated empirically. Started with fortified antibiotics and homatropine, vitamin C, doxycycline, ciprofloxacin, and ranitidine. As I explained, doxycycline, the rationale. And he had low hemoglobin, possibly because of poor nutrition, because of chronic alcoholism, and not a good socioeconomic status. He had abnormal LFT, splenomegaly. So we thought of tuberculosis, we thought of syphilis, and these were the two top conditions that we thought about. And the patient was treated, in the process of getting all these investigations done, the patient started improving. So day one, and then his vision also improved, and so and the genital lesion also showed reduction in size and in duration. And on checking up, ciprofloxacin, ciprobid, is one of the agents which is effective against treponema. So though we hadn't treated him with penicillin, we hadn't come to a definite diagnosis, but this was a case of syphilis. This is another example of a different patient, 47-year-old male with Sweet syndrome. He was diagnosed Sweet syndrome, which is an association of tuberculosis. He presented to us with sclerokeratouveitis and secondary glaucoma. This is what it looked like. And this is, we started on steroids because it looked very obvious. It was Sweets is an immunologically inflammatory reaction to tuberculosis. But if you really see, there is that little bit of yellowish appearance. So maybe in hindsight, what I said earlier, that 48 hours, just give antibiotics and see how it goes, but we started on steroids straight away and he definitely worsened. And here again, we are cautious. We never start 1 hourly steroids in such cases. We just started a regular 4 times a day, or maybe it was 6 times a day. I don't recall. And in such cases, again, see the patient after 2 to 3 days, because when you're not sure which way it's going to go, see the patient, counsel the patient also that, that it's very important for us to monitor what's going to happen. And you see again after 2-3 days, it definitely showed a worsening, and he progressed to necrotizing scleritis with PUK and exudative RD. He had been given systemic steroids as well. So he progressed. You can see how he progressed so extensively. And then the local lesion was tested. It tested positive for Mycobacterium tuberculosis. This patient has been reported. So basically, he had to be treated with ATT, and he subsequently healed completely without requiring any surgical treatment. Even the exudative RD settled down. This is another unusual case, a 26-year-old female who had a gradually developing whitish opacity and diminution of vision. She gave a history of 5 years. She had intermittent dull pain and redness. Provisional diagnosis was difficult. She had disc edema with scleral thinning and hypotony. So there was some kind of a communication and a leaking of the fluid from the eye. And her vision was 2/60 in the right eye and 3/60 in the left eye. MRI brain had shown hypophysitis, and we finally felt that it was a non-ulcerative perilimbal keratoscleromalacia, because there was no active inflammation or any active infective pathology going on, with hypotenuse maculopathy. She was 26. One was hesitant to operate, but because we tried the doxycycline, vitamin C, and hoped it would settle, but no, the vision progressively worsened. There were cystic spaces with scleral show, and there was progressive hypotonic maculopathy. Watched her for about a week or 2, and then finally she underwent a bilateral overlay, because here we have a communication, and there was a concern that if you try to do the procedures which had been shown earlier, that you excise and then you operate, there was a concern that you would be suddenly have a collapse of the eye during the surgery. So this was the unusual thing in this case, that an overlay corneoscleral patch graft was done, and here that posterior thinning technique which I mentioned, that you bevel it all round, so make the edge thinner so it's easier to tuck in, that helped a lot. This is the video, but I think this is another video of a patch graft for another patient, but I think Dr. Lomi has covered very nicely all the surgical steps. But here I would like to explain, even for a small graft like this, if you feel it is going to be difficult to fit it in, then do a beveling posteriorly. It can appear a little bit difficult, but it's not. And then such cases, you can also just apply glue, because a graft is so tiny that sometimes difficult to suture. So you can just apply glue, and fibrin glue is very physiological. It's no harm if it touches the iris. So you can apply the patch with the fibrin glue, stabilize it, and it works very well. This is how it looks post-op. As you see, nicely integrated. This is just the case of customizing the donor corneal patch, and then you just apply the glue. So this was the sutureless patch graft which we had described long ago, how fibrin glue can help. So you assess, you decide, look at the extent, you look at the options, and then you proceed. This is the various options for surgical treatment, and then rehabilitation. Sometimes you may even have to consider keratoprosthesis. So preoperative planning, we have this algorithm that we have reported in Konya 2002. There's a therapeutic and tectonic role. And photo ASOCT, I would like to say, is another useful tool because it helps you to look at associated scleritis. So this is very useful, and in vivo confocal microscopy can also help in such cases. Now, talking about another patient, this is a surgical case that Dr. Lomi showed. 13-year-old female had a diminution of vision for near and distance for 10 days. This is worked out by the senior resident. She was associated with redness, mild pain, photophobia, purulent discharge, and both eyes very, very swollen lids. She had been asymptomatic just 10 days back. So here this was 13-year-old child, was absolutely fine, and just 10 days back before she noticed a sudden onset pain, redness, discharge, and diminution of vision. And after 3 days, her symptoms in one eye aggravated. Then she noticed skin ulcers over the palm, leg, scalp, oral mucosa, and genitals. She consulted a private hospital and diagnosed acute mucopurulent conjunctivitis, suspected gonococcal, and was treated with topical fortified antibiotics as well as oral antibiotics with anti-inflammatory medicines, which I thought is a good diagnostic possibility given the cause. However, it would have been good if a conjunctival swab or a scraping had been done at that time, but she had no response at all. But it is important to look at the journey that the patient has gone through before coming to you. So this was helpful for us to know that adequate antibiotic therapy had been tried and she had shown no response at all. There was no history of any systemic illness, no previous episodes. Everything that possibly we asked for was negative. And she had this oral ulcer, and she had this kind of appearance on the edges of her mouth. She had, this is the lesions on the scalp, on the fingers, there were these ulcers, and then on the toe, different places. She was conscious, cooperative, and her systemic health was otherwise all right. This was her vision, 612 in the right eye, and just hand movements in the left eye, and these were her appearance of the eyes. So it was really, really a very dire state, very, very severe disease. Everything else, as I showed you, and then she was started on topical steroids as well as antibiotics, and gradually the patient responded. There was a clear lens, and ultrasound and conjunctival swab was negative. So we went systematically, made sure we ruled out infection, then started the topical steroids, investigated systemically mucopurulent conjunctivitis with PUK. Then so this is the sequence that we followed. Dermatology and immunology consultations were done, and finally Behçet's or a vasculitis sequelae was suspected, and she was treated with dapsone, azoran, and Visalone, and repeat blood. And meanwhile, of course, she had the surgery that was explained because one eye was really, and the patient did well till the 4th day post-op. Then again, she developed this peripheral ulcerative lesion, and there was wound gape which was present. This is how it started melting. So a repeat patch graft was done. The repeat patch graft was done by Dr. Lomi under GA. And skin lesions improved after treatment, and this is how the patient did subsequently. This is how she was 2 years after treatment. Discussion, these were the various possibilities that were considered, but eventually we came to the right diagnosis and the patient did well. So with that, I'll stop here because we have 5 minutes left for discussion. We wanted to basically show you there is a kind of a sequence that you expect and a certain known differential diagnosis, but sometimes unusual things do happen. And with combined shared care, one is able to give a good result. Thank you. Do we have any questions from the audience?
Hello. Very excellent instruction course we all learned here. I have one question regarding the steroids. You told about the dexamethasone. Instead of dexamethasone, you use prednisolone. I think dexamethasone and prednisolone both are potent steroids. And number second question related, can we, if we have a confusion of infection and the immunological type of ulceration, can we give a combination of antibiotic and dexamethasone like that, which are frequently present in the market?
Yes, a very good question. Thank you for asking. There's a definite benefit of dexamethasone that it is a solution and prednisolone is a suspension, so one likes to use a solution preferably. Both are potent, but the tendency to produce secondary glaucoma is higher with dexamethasone. But if using dexamethasone, you can use it 4 times a day, and if you're using prednisolone, then one could use it 4 to 6 times a day. We tend to prefer using prednisolone phosphate, which is P-lone, because it is a solution as opposed to prednisolone acetate. The second question is whether you can use both together. Yes, you can use both together. Now, which to start with first? So if you can either start with both together straight away, and yes, if your clinical impression is that you're using the antibiotic only to prevent secondary infection, and actually it is the steroids that are required to start straight away, and the presence that there is an epithelial defect, there could be secondary invasion, and you want to control the surface bacteria, etc., then you can use a broad spectrum antibiotic along with it around, say, 3 to 4 times a day. If, on the other hand, you're suspecting an infectious pathology where you're giving fortified antibiotics, there I would say don't give the steroids for 48 hours. If you feel that the immune suppression effect of the steroids is necessary, give oral steroids, unless you're suspecting tuberculosis. And after that, after the first 48 hours, depending on how the patient responds and whether you have any results of your investigation, then you do have to use both together. And the topical antibiotics you will use for about 1 to 2 weeks, or maybe shift to some gentle corneal epithelium drugs like chloramphenicol. But yes, you can use both together, definitely.
Thank you, ma'am.
Thank you, madam. It was a very nice instruction course. Like, what is commonly available in the market is the prednisolone acetate versus phosphate. Is there any difference in the efficacy between the two?
No. And again, I apologize to any of the pharma companies. I have no financial interest in any product. Prednisolone acetate is an excellent steroid. It has good penetration into the anterior chamber, and that is why it is beneficial. So there's no problem at all. You can use it 4 to 6 times a day, and you're right, prednisolone phosphate is less available. If you, for some reason, do want to give a solution, as doctor correctly said, you can use dexamethasone as well.
Thank you, madam.
Hello, ma'am. How do we approach a case, a contact lens wearer with a peripheral corneal ulcer?
Yes. So contact lens wearer with a peripheral corneal ulcer. Normally with contact lenses, we usually get a central ulcer, but you're absolutely right, you can get a peripheral ulcer. First thing is often, if it's a patient who's wearing a disposable contact lens, the first thing they've done is they've thrown away the contact lens. So in that case, you must send a culture from the not only the ulcer but also from the solution and the case. In case they haven't thrown away the contact lens, and the contact lens also should be cultured. Since it's a patient wearing a contact lens, it is better to err on the side that it is likely to be infective. So give fortified antibiotics for first 2 days. And usually from the appearance, you can tell whether you suspect a gram positive or gram negative, but you would give broad spectrum topical antibiotics. And rarely a contact lens may have been an ill-fitting contact lens, so they may have had hypoxia, and it may have maybe a sterile melt, or sometimes they're using the contact lens because they had rheumatoid arthritis and they had a sterile corneal melt, and that is why they're using it. So then you have to think that it may be an associated systemic pathology going on. So don't give the steroids straight away. Wait for 48 hours. Wait till you get the culture reports. And explain to the patient why. Yes. Okay, so with that, I'd like to thank all my co-instructors, Dr. Vanati, Dr. Lomi, and Dr. Sarat, and the audience for being present here, and the audiovisual team and the hall coordinators for making sure everything went smoothly. Thank you very much. Can somebody take a group photograph if possible? Anybody here? Or we can just give our phone.